This is E.Anbarasi, Assistant Professor, Mental Health Nursing, ES College of Nursing. Today we will see about delirium. First of all, delirium nothing but it is a brain fog. Moving to introduction. Delirium is a common clinical syndrome characterized by disturbed consciousness, cognitive function or perception which has an acute onset and fluctuating course. It is usually developed over 1 to 2 days. Two phases are there, acute phase and fluctuating phase. Acute phase nothing but suddenly happen, fluctuating course, symptoms arising on and off, usually develop 1 to 2 days. Next, to move on to the definition. Delirium is an acute organic mental disorder characterized by impairment of consciousness, disorientation and disturbance in perception and restlessness. Patient will have restlessness feeling and disorientation, not knowing about time, place, person. Next, incident. High incident level of post-operative care patients, and then 10 to 25% medical surgical cases, 40 patient of geriatric patient. Types of delirium. There are 3 types of delirium: hypoactive delirium, hyperactive delirium, mixed delirium. Hypoactive delirium, this may include inactive or reduced motor activity, sluggishness, abnormal drowsiness. Hyperactive, this may include restlessness, patient feel very restlessness, agitation, increased psychomotor activity, rapid mood changes, hallucination present, hallucinations, false perception. It mainly visual hallucination patient will have. Mixed delirium, this included both hyper and hypoactive delirium symptom. This person may quickly switch back from hyperactive to hypoactive state. Etiological factor. These are all the etiological factor cause the delirium. First one, vascular. Hypertensive encephalopathy, infection, encephalitis, meningitis, neoplastic space occupying lesion, intoxication, chronic intoxication or withdrawal effect, traumatic subdural and epidural hematoma, heart stroke. Next, vitamin deficiency, lost thiamine. Next, clinical feature. Impairment of consciousness, clouding of consciousness, ranging from drowsiness to stupor and coma. The mental status and level of consciousness commonly fluctuating throughout the day. The symptoms fluctuating throughout the day. Impairment of attention, difficulty in shifting, focusing and sustaining attention. The patient never concentrate the communication. Then perceptual disturbance, illusion, hallucination present. Illusion means false unshakable belief, hallucination means false perception. In mainly occur the visual hallucination. Disturbance of cognition, impairment of abstract thinking and comprehension, impairment of immediate and recent memory, increased reaction time. Psychomotor disturbance, patients will have hypo and hyperactivity, aimless grabbing or picking at the bed class. Disturbance of sleep-wake cycle, commonly present insomnia, or in severe cases total sleep loss or reversal of sleep loss. Sleep-wake cycle, reversal of sleep-wake cycle, daytime drowsiness, nocturnal worsening of symptom, disturbing dreams or nightmares which may continue as hallucination after awaking. Emotional disturbance, depression, anxiety, fear, irritability present. Other symptom, difficulty maintaining focusing, changing subject frequently, disorientation, place, person, time. Diagnostic criteria, history collection, a detailed review of all medication, any new medication adding, any changes or reason withdrawal any medication. Inquiry about sleep pattern, pain, substance use, reason injuries. Neurological examination to rule out the brain focal injury. Example, stroke. Blood test, complete blood count, electrolytes, glucose, kidney and liver function test we rule out. Urine test to check urinary tract infection, chest x-ray to check for pneumonia, drug and alcohol screening to check for intoxication or withdrawal. Brain imaging may be ordered if stroke, bleeding or structural issues are suspected. Confusion assessment test focus on 4 key features, not all which directly test memory. Acute onset and fluctuating course, inattention, disorganized thinking, altered level of consciousness. Attention we test the most critical features often with a task like month of year backward. If positive diagnosis means present 1 and 2 or 3 and 4. Medical management. The delirium management includes supportive therapy and pharmacological management. Supportive therapy, we give fluid and nutrition. This should be given carefully because the patient may be unwilling or physically unable to maintain a balanced intake. The patient suspected to have alcohol toxicity or alcohol withdrawal therapy should include multivitamins, especially thiamine. Environmental factor. The environmental factor should be stable, quiet and well lighted. Physical restraints should be avoided. Medication, neuroleptic, short-acting vitamins we will give. Doctor will advise neuroleptic. First of all, haloperidol 0.5 to 5 mg TDS, risperidone 0.2 mg to 2 mg BD. Short-acting, lorazepam 0.5 mg IV or IM. Vitamin, thiamine hydrochloride 100 mg IV. Cyanocobalamin 100 mg IM. Monthly once. Nursing management, providing safe environment, restrict environment stimuli, keep unit calm and well illuminated. There should be always somebody at the patient bedside reassuring the supporting, alleviating patient fear and anxiety. As much as possible, have the same person all the time by the patient bedside. Meeting physical needs to be patient. Appropriate care should be provided after physical assessment. Use appropriate nursing measure to reduce eye fever if present. Maintain intake output chart. Mouth and skin should be take care. Monitor vital signs. Facilitate orientation. Repeatedly explain to the patient where he is and what date, day and time it is. Conclusion. Delirium leads to increased mortality and morbidity and longer hospital stay. In addition, many patients with delirium will not return to their pre-hospitalized functional state and will require long-term care. Thank you.